Our final speaker for today's keynote session is Associate Professor Anne-Marie Hill. Anne-Marie is an NHMRC Early Career Research Fellow at the University of Notre Dame in Australia. She is based at the School of Physiotherapy and Institute for Health Research, where she's leading a research program investigating healthy ageing and falls prevention. Anne-Marie, welcome to the stage.
Hello everyone, and thanks for taking the time to stay and listen to the presentation after 2 very long days. I'd like to particularly acknowledge the research team that worked to complete this very large study, and I just hope I move it forwards. This trial was funded by the State Health Research Advisory Council, which supports research in Western Australia and is part of the WA Health Department, so of course we thank them. I'd like to acknowledge and thank the institutions that supported the research, and special thanks to the WA Falls Community of Practice. I don't know if some of the members are still here now, but they really helped with getting the trial running at so many sites. It's obviously a very large trial. Just as a little quick background, you will have heard this over the past few days, but it's probably just worth summarising that falls in rehabilitation wards, we know, are higher. There are higher rates of falls in those wards than in other areas in the hospital. And of course, we've heard over the past couple of days that while multifactorial interventions have been shown to reduce falls, it's hard to know with clarity what actually could reduce falls, what components of those interventions. And we do know that large trials, randomised trials, have shown that bed alarms and low beds are ineffective strategies. So what I'm going to ask you to do is actually just to try and turn yourself back a step, and if you think behind before you even implement strategies, and think, how do falls actually occur in hospital? What is actually happening? And I'd just like to show you a video that we've made in WA, and I'm going to show you the first part now, to actually just get you to think about, what makes people fall over.
For 6 years now, the cornerstone of falls prevention in hospitals has been multifactorial assessment and intervention. We fill out tools and then we do stuff to patients. We've been looking for that extra bit that we can do, the missing piece. We've focused on the environment, we've worked on staff behaviour, but we haven't done as well as we could with patients.
So we asked ourselves, why is it that some patients have the same risk factors, yet some of them fall and some don't?
We've been superficial with education. We've been giving pamphlets, we've been calling them non-compliant. We haven't really delivered education to patients using adult learning principles. Chris is busting. He's getting frustrated. He uses the call bell, but no one comes. He makes a decision to go to the toilet without his frame and without the assistance he needs.
So if we think about the epidemiology of falls and looking at that fall event, that's a very common scenario. We know that falls are not just about patient risk. Falls are a combination of the environment, the patient, and the staff actions. So falls happen somewhere in between those three factors. And if we look at a recent really large hospital data done by Ron Shaw and colleagues, we can see that it confirms other large observational studies which show that over 80% of falls occur when the patient is by themselves, when they're unassisted. So what that really tells us is that knowingly or unknowingly, patients often retain the locus of control. Patients are at the centre of falls occurrences. And we know that rehabilitation involves graduated movement and recovery. So we can't realistically, and it wouldn't be good for us to suggest to patients that they don't move around to reduce falls. But the question is, what's the level of risk that patients should take? And qualitative work that we've done shows that patients have various reasons for taking risks. And one of the issues we have, of course, is that some of them take risks that are not going to be a risk that's safe for them. The risk is going to be malformed, and it may be that they have a fall because the risk they've taken is too great. So if we think about that, it then tells us that perhaps an intervention that centres on the patient and gives the patient control of the situation is going to be something that helps. And we do know that giving patients education does have some evidence of benefit, and we heard that in the meta-analysis by Angel yesterday. And we know that there is some evidence of benefit. And in other work we've done as part of the team I've worked with Terry Haynes, we know that falls prevention education, particularly we've delivered ours using very sound adult education methods and health behaviour concepts, gives people, older people, an idea of falls prevention in hospital and gives them confidence and motivation. So there has been a large trial which was led by Terry Haynes in 2010, and in that trial patient education was delivered as a single intervention. Now, it did not reduce falls rates overall, however it did reduce falls rates significantly in the subgroup of people who had better cognitive levels. However, it increased injurious falls rates in patients with impaired cognition. So something was happening in that trial, something effective, yet there was also an unintended consequence as well that wasn't so good in that falls increased in one group. So could we tease that out and find out what was happening? When we looked at that intervention and we looked at the feedback from the patients and from the educators who delivered that intervention in the trial, and I was one of those educators, we found that when patients gave us feedback, if I frame it to you in terms of health behaviour, we had given the patients the capability to do good falls prevention actions. So we'd told them about falls, we'd made them aware, we'd helped them address barriers and understand what they needed to do. And then we had given them the confidence and motivation to have a safe recovery and prevent themselves from falling. But what our patients constantly fed back to us was that they felt on the wards they lacked the opportunity to change their behaviour. They lacked the physical and the social opportunity. And the way I might just give you an example of that is, say you decide that you want to be more healthy and you're going to ride your bike to work. But between your home and work there's no bike path at all. And say your family also react with horror to that idea and say, don't ride your bike to work, it's too dangerous, please don't do it. You're not going to have the physical or the social support to do an activity that would make you fitter. And that's what our patients told us. Well, I've planned to ring my bell, but the trouble is my bell isn't in reach. I would like to use my walking aid, but another patient borrowed it and I don't have it to use. And also patients commented that staff didn't affirm them and give them encouragement when they did enact the behaviours that they'd planned. So they didn't get any positive feedback. But remember, this was a randomised trial with blinding, so as educators we weren't allowed to give staff any feedback about what we were delivering to the patients. And also, in this sort of trial, perhaps we had a good effect in some patients because we enrolled patients that were keen to do something about falls prevention. So in fact, what might happen if we tried to intervene or do this intervention in a more realistic clinical environment? So the aim of the trial that we then undertook was to evaluate the effectiveness of providing this patient education, this time with staff training in addition to usual care as a cluster trial in hospital rehabilitation units, and also to evaluate the economic effectiveness of providing this patient education. Now, I'm going to report on the clinical results today and not on the economic analysis. So the trial design, we used a Stepped-Wedge Cluster randomised controlled trial. And in this trial, in this type of trial, all 8 sites start in the control phase, and the intervention is rolled out at regular intervals site by site till all sites move into the intervention phase. Now, the randomisation is in the timing and when sites will move into the intervention phase, and that randomisation is completed before the trial commences. The Stepped-Wedge design is a useful design for where you want to implement an intervention as part of routine care that's already underway. And the other advantage of a Stepped-Wedge design is you can examine the effect of the intervention over time. So we randomised 8 rehabilitation units that are part of WA Health Department, and I'd just like to take this opportunity, and again, I'm not sure which of our Falls community practice members are here, but to thank the people that helped us at those sites to deliver this trial, to do this trial. We had 267 beds, and our sites varied, so we had as small a site as a 16-bed GEM unit, and we had a really large unit of 90 beds. Now, our units varied too. Some delivered services that could incorporate people who had dementia, others provided stroke rehabilitation for older people, so very big mix of the type of aged care subacute units. The participants were, I would surmise, maybe a very similar population to your older people in rehabilitation units. Post-fracture, post-hip fracture was a large diagnostic category. Post-falls, post-medical, pneumonia, myocardial infarct, post-surgery, so really large, broad population. On the wards themselves, the teams were all led by geriatricians. They included aged care experienced nurses, experienced, allied health teams, access to 24-hour acute services as required. And all our sites in WA Health operate a mandated falls risk assessment and management program. So everyone without exception, we hope, but audits show fairly good compliance. Everyone receives falls risk management and assessment. So that was our baseline usual care. So I'm just going to show you now a short snippet to give you a bit of a flavour before I describe the intervention. I'd just like to show you just a little bit of an overview of how the intervention it works.
The assistance he needs.
We thought, could patients themselves be more engaged in their own falls prevention? So in our first trial, we found that patients really understood the message when we delivered it clearly and simply. Patients were able to change their behaviour and be safe in hospital, which was what we wanted. But we thought, can it work in a real clinical environment across a whole ward with staff support? Can it change behaviour in that way? So Chris, how did you enjoy that video?
I enjoyed it, but I didn't realise so many people fell over in hospital.
So we give patients this simple 3-step message about knowing if they need help, asking for help and waiting for help. But what we do is provide it in a way that patients really understand, because we give them the principles underlying why they would need to take risks, and we tell them and explain to them how the process of being in hospital works. Once patients understand that, they change their behaviour. When you are asking for help, have you been ringing the bell for help?
Yes, several times.
Okay.
Yeah, about 3 times.
Yeah. Have you noticed people coming, or have you felt you've had to wait a while?
I had to wait a little bit.
Yeah.
Not too long, I don't think, but it gets a bit frustrating sometimes when you have to wait for the bell.
It can get a bit frustrating. You will have a nurse looking after you, and when you ring the bell, your nurse will definitely come. So she'll be on the alert when she sees your number go, sees your bell ring. She'll think, right, I know Chris needs some help, and she'll be in.
Okay.
If you wait, someone will always come to give you a help.
Okay, so I've got to wait a little bit.
Yeah.
Yes.
Yeah. How do you feel about waiting? Are you used to waiting?
Well, living by myself, you do things naturally by yourself normally. Don't have to wait, but yeah, I'll have to wait then.
Yeah.
Mm.
Yeah.
Yes.
Do you feel like you could be fairly patient for a few minutes and wait?
I think I could hang on a bit, yes.
Yeah, that's good. If you think in 5 or 10 minutes I think I'm going to need to go to the bathroom, give the bell a ring then. And that way by the time the nurse comes you're really beginning to think about going.
Oh, I never thought of that one.
Yeah, so it's just a bit of forward planning. That normally works
That's
well.
a good idea.
Yeah. All right, well, thanks for your time, Chris, and I will come back and see you tomorrow and we can just check over and see how you're going with moving around safely.
Thank you for seeing me.
Oh, you're very welcome. So it just gives you a tiny summary, but essentially when we work through this education with patients, we're giving them some background knowledge. We're discussing barriers and finding out what they think about falls risk, and we're explaining the whole processes of the ward to them. And this education is delivered by a trained physiotherapist who's received 6 hours of online training and follow-up to know how to deliver the education using the principles of health behaviour change. The education delivery starts with a DVD, and patients also read a workbook, and then they receive a series of follow-up sessions from the educator, and they get help to write an action plan. And follow-up sessions, when the educator comes back, they discuss barriers and enablers with the patient and actually congratulate and affirm the patient on successes that they've had. So it's a matter of really working with the patient so they take that locus of control. Now, it is a ward-based intervention, and what happened was when the educator visited, they first provided orientation to staff formally and then ongoingly informally, and also liaised with staff on a weekly basis. So the educator would provide formal and informal feedback to staff about barriers that patients reported. And the educators encouraged staff to affirm patients when they enacted their plan, and the educator encouraged patients to speak up to staff if they notice something wrong. So it's a matter of linking up the patient with the staff in a positive, uplifting sort of way. So our primary outcomes were falls and injurious falls, and also the proportion of patients who became fallers. Based on our own work and that of others that you've heard, we used multimodal data collection to try to capture all falls. And our statistical analysis did include an a priori subgroup analysis, because we obviously were going to deliver our education to cognitively intact people. So our ward was essentially going to have a more active group that received the education. Okay, so what were our results? You notice that in our demographics, approximately 50% of our patients have some form of cognitive impairment and so don't directly receive the education. And our length of stay is about 12 days, reflecting that rehabilitation population. I'm only going to present a very quick summary of our process outcomes. So essentially, our educators managed to deliver the intervention to about 90% of eligible patients, and education median number of sessions provided was 2, median time approximately 45 minutes. About 93% of patients completed a written action plan. And remember, this was a ward-level intervention, and the educators provided about 400 hours of staff education and feedback to staff as well. What were our falls outcomes? There were 576 falls over the 50 weeks in the 8 units, and of those, 196 were in the intervention period, 380 in the control period. So our unadjusted analyses showed that there was a significant reduction of falls and injurious falls and proportion of people who fell in the intervention group compared to the control group. When we adjusted for pre-planned factors such as age, number of comorbidities, and adjusted for the step time entry into the trial, the difference remained significant for falls rates. So falls were significantly reduced in the intervention group compared to the control group. And falls rates also remained significantly different. Injurious falls rates remained significantly different. And the proportion of people who fell in the intervention group was also significantly reduced compared to the control group. Now, there was a significant cognition by intervention interaction, and we completed our subgroup analysis, you can see that patients who have impaired cognition still fall less on intervention wards compared to the control group. And what we're saying here is we're expecting a larger effect in the cognitively intact group because they directly receive the education. But falls rates are still lower in people with cognitive impairment on those intervention wards who didn't receive the education. So there is a beneficial effect occurring across the whole ward. Our program evaluation is ongoing at present, but I just want to highlight to you some of the early results. What we found was that our educators reported that they felt their role was to be like a mediator, where they linked staff and patients in a positive way. So they were able to mediate a supportive reaction. And they were able to help with feedback loops to get staff and patients to be on the same page. So for example, the patient realises the need to ring the bell. The staff realises to affirm patients and encourage and give them positive feedback when they ring the bell. And both the patients and the staff realise that to ring the bell is going to need to be in reach. And so our patients can get up the courage to actually say to a staff member, oh, excuse me, could you put my bell in reach? Because a lot of our patients reported to us in the first trial, they felt very anxious about saying that because they might get in trouble. So this gave our patients confidence to speak up, and then it gave our staff confidence to go, I know those patients know what they're meant to be doing, I can feel confident. So I just want to actually sum up for you some of how that might occur now.
Thank you for seeing me.
Oh, you're very welcome. The reason we think this trial was so successful is that we informed the staff as well, so the staff were able to support the patients, give the patients confidence, help them to understand. That staff support is really key to the program actually working.
Hey Chris, thanks for
thank
waiting.
you.
How can I help you?
Thanks for being here. I'd like to go to the bathroom, please.
Yeah, sure,
Okay.
no worries.
Very good, thank you.
And after your physio review, how are you mobilising?
This I have to use a Zimmer frame, yes.
Yeah. All right, I'll just grab it for you.
Okay, thank you.
Falls and injurious falls were significantly reduced across the whole ward, and it's important to realise that that included patients with cognitive impairment who didn't receive the education. So this shows that delivering this program in the way we did can really benefit the whole ward. What we really need is a trained educator who can be on the ward and do that mediating role that can be between the patient and the staff and help everybody to get on board with the safe recovery message.
For those in healthcare who are making decisions about service development, for managers, for clinical staff, for geriatricians, for allied health staff and nursing staff, it's important that we take this information and we ensure that it goes into clinical practice. This is a no-brainer.
So what's some of the conclusions of our trial? I think it's noteworthy that we had a reduction in injurious falls, and I think this is really important because our data, as with other trials, show that about 30% of falls are injurious, so it's good that we can reduce the injuries from falls as well as falls themselves. This trial was effective for across the whole ward, and I think it was because we enabled a successful feedback loop, and it addresses factors that patients directly find lead them to take unintended risks, so that's very important. But what it also does is provide staff with tailored feedback. Once 4 or 5 patients tell them that the corridor is cluttered, they get the message, they pick up on it because it's direct, instant feedback. This program has been tested in a real-life clinical setting. Our wards would be, I'm sure, identical to many of the wards that you work on. There was nothing fancy or different about any of our wards. So this intervention can be delivered with fidelity because it has a training program to back it up. So our educators could be clear on exactly what they should be doing. So in conclusion, we found that this individualised education provided as part of ward clinical care reduced falls and injurious falls in older patients. We think that hospitals should incorporate this type of education into their falls prevention programs that are delivered in rehabilitation units. And just to give you a quick heads up for the future, we've received funding to trial a novel patient education program for preventing falls after hospital discharge. So I hope to come back in a couple of years and tell you what we've been up to with that. But meanwhile, this is the citation for being able to read the full results, which aren't out yet, and I'm very happy to take any questions. Thank you.